Hey everyone, thank you so much for making it. My name's Tiffany Wood. I am one of the research chairs for our research committee, and super excited to see some folks from our committee joining us, as well as folks, out there from PCOM land and everywhere else. Thank you for being here. Thanks to TJ for talking to us. So anyone who doesn't know TJ, he is an OMS2 at PCOM, and he's been working on a nerve and tendon transplant PowerPoint. He's gonna present this for a 400 level science class, neuroscience class, but we are lucky enough that we get to hear from him here as part of AOC PM&R. So thank you so much, TJ, for giving us your time, and we are very excited to hear from you.
All right, so let's do it. All right, can you guys hear me okay? Awesome, I got disconnected. So this is a PowerPoint I've been working on. I'm teaching it to undergrads next week. So there's a lot of information that we can breeze over because most of us here are medical students and we've been through this already. Dr. Saruya is my mentor. He's the person who inspired me to be a doctor. And I feel really fortunate that I've been able to work with him for the last 8 years. And this is kind of like what his research is on and what our research is on. So you guys know what the muscles are. We know what the dermatomes are. You can skip through all this good stuff and get right down to it. This is the brachial plexus. Nobody likes the brachial plexus. But what I want you to pay specific attention to for the purpose of this lecture is how the C5 and C6, they feed in here to C7. And C8 and T1, they also feed into C7. This is going to become very important later, this redundancy that we actually have in the posterior cord. So here's a picture of a brachial plexus in a human, and then there's a schematic of the brachial plexus. So some ways that you can injure your brachial plexus from birth actually can come from the force that a surgeon exerts on the baby's head. So you can see there is a shearing here occurring when the shoulder is getting depressed by mom's pelvis while the surgeon is pulling baby's head out. And this can result in a few different injuries. First, you have a neuroma, which is kind of like a tumor-like growth of a nerve. You can just have a straight up rupture, or an avulsion, which is a tear from the root. You can avulse a tendon off a bone. That's another example of an avulsion. And these things can manifest as a series of palsies like cerebral palsy, Herb Duchenne. Let's hide that. There we go. Here's some examples. And again, you guys don't have to memorize this to get the point. This is just the introduction to give you an idea of the types of diseases that we have to focus on curing. So in C5 and C6, you can see that there's this Erb's palsy and C8 and T1. You have a Klumpke palsy, and they have very different manifestations depending on where in the brachial plexus we're seeing these tears occur. Some other ways that people tear their brachial plexus can be trying to catch themselves through a fall. I know we've all seen this a million times in the movies, but it's just not realistic. That person most definitely tore their brachial plexus trying to catch themselves from falling off that cliff. Because look at this. There's a separation here in the armpit, and that's going to cause the bottom half to experience a tear, whereas a force driving your head over away from your shoulder really rapidly is going to cause more superior tear. And please, guys, just don't get a motorcycle. Here's some more images of ways people can tear their brachial plexus. Again, we just love motorcycles and we love trees. So we can skip through the blood vessels, and now we can start talking about tendon transfers. So tendon transfers is where you can take a muscle that doesn't work, and then you can take a working muscle to innervate it and allow it to function, to somewhat function again the way that it's supposed to. They were really inspired by the polio epidemic because there were a lot of people who couldn't move, and they had somewhat working limbs, and we were trying to salvage what we could to restore function back to these people. World War I and World War II, we saw a lot of disfiguring injuries. This is where PMR came out, but we also needed a lot of innovation in terms of how we were treating people with a variety of injuries. The people who get tendon transfers, usually peripheral nerve injury, or someone who had a failed graft or transfer. They're also indicated in people with motor end plate fibrosis, which is basically like a fibrosis between where the nerve connects in with the muscle, and it's literally impossible for the nerve to communicate to the muscle. So what is a tendon transfer? So we can give it to people who have radial nerve palsies and things like that. So here is an example of a tendon transfer. So we have a pronator teres taking over the function of the extensor carpi radialis brevis, I believe. Yes. And when we connect this tendon over here into this muscle, this person who previously had a wrist drop is now able to lift their wrist back up by using a normally functioning muscle. So if you have a radial nerve palsy, your extensor carpi radialis brevis is going to be essentially not working. It's going to be offline, but your median nerve powers the pronator teres. So your median nerve can take over the job of the radial nerve and extending the wrist and enabling you to grab objects and be able to stabilize loads. So here's some other examples of tendon transfers in the hand. So this is the extensor digitorum communitus, I think, and the flexor carpi ulnaris. And you can see that the flexor carpi ulnaris is literally pulled around to the posterior half of the hand, and it's re-enabling this person to extend their fingers and prevent that wrist drop and get that wrist lifted back up. Over here, this is a bit more extreme, but again, we have these anterior structures being moved posteriorly to give us that function back. Here's an example in the OR of this flexor carpi radialis to the extensor digitorum, and you can see that it's being pulled around, and this is where it would extend. And so this tendon would pull back this way, allowing us to get our wrist back. So this is where we start talking about nerve transfers. The first nerve repair was actually described by Paul Avicii back in the 7th century, which is like forever ago. But I guess if you talk to someone who studied philosophy, they'll probably tell you the Greeks knew everything. And then in the mid-19th century, we saw that the neuron was first described. And then in 1905, Ramon y Cajal, they were very famous in a lot of early neuroscientific research. So the first ever successful nerve repair was apparently described by this person named Cruikshank in 1795. I have no idea what they were doing. It's impossible to find any information on this, but apparently that was it. I don't know how successful it was. I don't know how they determined what was successful. But for a long time, this was largely looked at as a salvaging type of surgery. And this is like last resort. We don't know what we're going to get out of this. And during, again, World War I and World War II, very similar to the tendon transfer, we had a lot of very unique trauma. We had a lot of very unique injuries, and we needed to get better at this kind of treatment modality to give function back to people. But generally speaking, there were relatively poor outcomes with an occasional success here and there, but people were doing the best they could. And then Dr. Milesi came around, who is this physician scientist, and he came up with a very good nerve grafting technique. This was adopted around the world, but the problem is that results seem to have plateaued until the 80s and 90s. And then in 1994, a paper was published showing that maybe that this is more than just a salvage only procedure. So let me go in and give you a brief overview of what a nerve transfer can look like. So here we have a person with a severed musculocutaneous nerve, and you can see the musculocutaneous nerve, as you all know, is the biceps, the coracobrachialis, and the brachialis muscle. This is severed in this case, and it's not going to innervate this biceps, this flexor muscle. So what we can do is we can actually graft and take the ulnar nerve and we can fuse it in with the musculocutaneous nerve, and the ulnar nerve will begin to feed information to the musculocutaneous nerve, and we can get function back to these people. You can actually lose about 80% of your motor axons without a clinically evident loss of function. And I really want to emphasize the clinically evident part, because it doesn't mean that you're going to go set a bench press world record, but it does mean you'll probably be able to send text messages on your phone, you know, hold objects, go grocery shopping, and have a sense of normalcy again. So for a lot of people, this is very, very life-changing. So, you know, nerve injuries are diagnosed through EMG, nerve conduction studies, and MRI. Really quickly, I'm going to show you some videos about how people's lives have been impacted by nerve transfer surgeries. There we go. Oops. What is going on?
When you go to open the link, you might have to unshare your PowerPoint screen and then share like either whatever internet browser comes up.
Oh, I see. Okay. Oh.
Welcome
My internet is my volume okay? Can you guys hear me well? Yeah. Oh, geez. YouTube's not loading anything. No. Please, YouTube, I'll do anything.
I think TJ might have lost his connection. Let me see.
He's still in the room.
Hey, TJ. Oh, gosh.
I'm going to check in on GroupMe.
Yeah. There he is.
All right, guys, I'm so sorry. I don't know what happened there. I'm going to just hope that this doesn't happen again. All right, so right back to it. I'm going to share my screen. Let's see here. This is an example of how, can you guys see this okay? Can you see this video? Cool. Can you hear it? Is there volume?
Pretty much everything that I've taken for granted before that I am doing.
A little bit, it's just really low.
It's really loud.
David suffers from an injured phrenic
It's
nerve
quiet.
that has paralyzed his diaphragm, crippling his right lung.
When we breathe, our brain sends a signal to the diaphragm, which moves and allows us to take air into our lungs and then contracts and allows us to breathe out. The phrenic nerve carries that signal from the brain to the diaphragm.
So a patient that has injury to one phrenic nerve will have a paralysis of the diaphragm muscle on one side. So it's essentially like breathing off of one lung.
David found UCLA doctors Reza Jerahi and Dr. Matthew Kaufman at UCLA after previous doctors told him there was nothing they could do.
He could no longer hike. He couldn't exercise at all. He could barely bend over to tie his shoes. And this was all a result of the phrenic nerve injury on one side of his body.
The hardest thing to hear from our patients is that their doctors for years have told them there are no options and that they would just have to live with this for the rest of their lives.
But advances in nerve decompression and transplantation allow reconstructive plastic surgeons at UCLA to reverse diaphragm paralysis for patients like David, giving them back their normal lives.
To our knowledge, we are the only center that is offering this procedure on the West Coast, and one of only 2 centers in the United States.
In surgery, x-rays are taken to confirm how much David's lung capacity is compromised. Doctors Jerry and Kaufman then locate and delicately remove the scar tissue, freeing up the phrenic nerve and restoring its ability to conduct messages from the brain. Finally, a nerve graft from David's ankle is used to bypass the damaged area, providing a new pathway to the crippled diaphragm from the brain.
And sort of jump over that area of injury so that he can have much stronger nerve signals going from his brain to his diaphragm.
The results are immediately encouraging. David's troubled lung is already filling with air.
The muscle has greater tone and so has a different position on the X-ray. And if we see that, we know we're off to a good start.
Within 24 hours, David's breathing is markedly improved. And a few months later, David returns to UCLA with a new outlook on life.
It's so much better. But now I can do exercise, hiking, riding the bike, swimming. And before I couldn't do pretty much anything.
Help is available, and when physicians tell their patients that just learn to live with it, we like to be able to tell them otherwise.
All right, so there's one. This is a quick one. I'm going to skip most of it. Can you see this video?
The surgery to do brachial plexus is not quick. The techniques that we use will stretch over an operative procedure that may be 3 hours, maybe 6 hours, maybe 10 hours, maybe 12 hours in length. And that all depends on how many nerves are injured and how many nerves the patient has available to reconstruct.
We generally will have more than one surgeon in the room when we do these cases. And that's a lot better for the patient for a number of reasons. One is that we can work simultaneously, and so the cases are faster. And so faster surgery is safer for the patient because they're under anesthesia shorter time, the wounds are open in shorter amounts of time, decreased infection rates. But the other thing is that it's very good to have another surgeon there to discuss intraoperative decision making. Because different from other surgeries, when you get into nerve surgery, you will have to make decisions as you're there. You can only know so much beforehand. And then during the case, you're still evaluating the nerve. You have different techniques during surgery to evaluate the nerve.
We'll have a pathologist standing by who will receive specimens from the operating room, small slices of the nerves that he or she will study under the microscope and tell us how scarred is this nerve, how intact is this nerve. We have to graft from a nearly 100% viable nerve to the recipient nerve. Otherwise, its chances of functioning are compromised on day one. We'll take nerves from the back, we'll take nerves from the chest, we'll take nerves from other working nerves in the arm, and we'll move portions of them to reinnervate or reconnect those nerves that are not working. That's the revolution that's occurred in the last 20 years. It's called nerve transfer. And the understanding that we can take a portion of a working nerve without damaging that nerve and move it to repair or reconstruct a nerve that's not working is revolutionary.
All right. Let's see. Can you see the PowerPoint again? No.
So I've been getting lots of requests from students
No,
as well
not
as
yet, not yet.
viewers asking to make a video on how to read a MRI.
You can't see the PowerPoint?
Not yet.
No.
Oh. Let's see. Does it show up?
We still
No.
see YouTube.
Still see me. Do you guys have any experience with this? I'm trying to.
Yeah.
Oh, here we go. All right, there we go. There we go. Now that should be up, right?
Yeah.
All right, great. I'm so sorry about that. So here is, we all know EMG, we all know nerve conduction studies. This is just some information on what an MRI is. And now we're going to get back into some papers. So this is a paper looking at the restoration of elbow flexion in patients who suffer from acute flaccid myelitis. So acute flaccid myelitis is a polio-like disease. It generally affects children, and it starts off with fever and respiratory illness, but very shortly after, they'll start to show this sudden arm or leg weakness, and you'll see a facial droop and other neurologic symptoms that would be kind of weird in a flu. And there's very limited data, but it suggests that people who, if you don't recover within 6 to 9 months, you're probably not going to recover at all. So that's where surgery comes in. This is an MRI, and it's showing some of the damage the polio virus has done to the central nervous system, or that it's just living in there. Something I want you guys to pay attention to is this score. It's called the Active Movement Scale. This is AMS here. This is going to be very, very important for the next 2 studies we're going to look at. So this paper basically evaluated a transfer of an ulnar or a median nerve fascicle to the musculocutaneous nerve. And before they took the nerve, it was required that they would still have 5 out of 5 strength before repositioning, or I'm sorry, it was required that they had 5 out of 5 strength in this nerve before they repositioned it. So here's some pictures of the surgery, and right here is where they are fusing fascicles from one nerve into the musculocutaneous area. Occasionally, they would take nerves from intercostal spaces, and the results were actually fantastic. So they had to exclude 10 participants, but of the 15 that they evaluated, 80% achieved excellent elbow flexion, which was an AMS 6 or 7. And then only 1 patient didn't really make any improvement at all. So we can take a look at the numbers. I really don't know what this Toronto score is, but let's just focus on the AMS on the left. You can see a 1, a 2, a 3, a 1, a 1. And then we take a look over here on the right, and we see a 6, a 5, a 7, a 5, a 7. So this surgery was actually life-changing for a lot of these patients, particularly these 2, where they went from zeros to excellent score range. And that's like definitely something worth taking note of. So some key points from the study, though, is that the longer you wait to fix these types of things, the less recovery they might have due to that motor end plate degeneration I was talking about before. And there was no one who lost any hand or wrist function from the fascicle transfers, meaning that this isn't it's not the most dangerous thing in the world when it comes to trying to give somebody their function back. This is another paper here, and they looked at something a little bit more proximal. And so they were, again, studying acute flaccid myelitis, except trying to get external rotation and focus on joint stabilization. So just a quick reminder for all you guys that the suprascapular nerve is responsible for the supraspinatus and the infraspinatus, and these are our external rotators. Here is a picture of the brachial plexus, and you can see that the suprascapular nerve is coming off right here and making its way down. So I seem to have missed this part right here. Sorry about that. But they had 8 participants who got a spinal accessory nerve to suprascapular nerve transfer, and 5 who got intercostal nerves into the axillary nerve. So here's a picture of the transfer. And in the green here, this is our suprascapular nerve. This is some blue in the black. And then this is our, oh, I'm sorry, the green is the spinal accessory nerve, and then the blue is the suprascapular nerve. And here's a schematic of showing what's going on, where the suprascapular nerve should be here, but we're taking our spinal accessory nerve and we're connecting it here into the suprascapular nerve. And the external rotation scores are fantastic. These are super good. But I circled the abduction scores because the abduction was actually not as good as the authors had anticipated. And believe it or not, it's because the virus may have caused a significant amount of damage due to its travel through the nerves in the axillary region. And it's not completely understood as to why this happened. But again, these are people who had relatively no functioning prior to participating in the study. And they were either walking away with some ability to abduct, which is definitely better than none, and fantastic external rotation. We can skip that one. And here is one of my favorite studies in this whole presentation. This thing absolutely blows my mind. This is a C7 to C7 transfer. The main thing I want you to look at here is this Fugel-Meyer score. Fugel-Meyer is basically a measure of sensation, coordination, and strength. And it's on a 0 to 66 scale. At the end of this study, people were gaining about 20 points on their Fugel-Meyer. And this is pretty much a study where they took the C7 on the left side or the right side, and then they quite literally hooked it up contralaterally to the other side of the participant's body. So some very interesting things that I didn't know is that the C7 nerve accounts for roughly 20% of all the brachial plexus, and it has a lot of overlap. You can see here, these guys are coming in and they're essentially doing the job for C7. So if we cut C7 here or here, we're really not missing out on too much data. And apparently clinically, if you do this, there's only a transient weakness. And what that means is there is a brief loss of strength and numbness, but it seems to resolve over time. And here's a schematic showing what exactly they did. So we have this was studying brain injury patients too, I should mention. They had stroke, cerebral palsy, and hemorrhage. So if you have a lesion on the right side of your brain, whoa. If you have a lesion on the right side of your brain, then your left side is paralyzed, as we all know. So what we did here is we took C7, hooked it over into C7 on the non-functioning side. So in this way, we're taking motor signals from the left side and then we're delivering them over to the left side because that's what we need. And here's another image further illustrating that. This on the right is, I don't totally remember what's going on here. There's some stuff with transcranial magnetic stimulation, but it's really, really well illustrated in the next study and also in the figures I'm about to represent. So after they underwent the C7 to C7 surgery, we have a surgery group and a control group. The surgery group was gaining roughly 18 points, 17 points back on their Fugel-Meyer scores, whereas the control group who just got PT, they really didn't make too much improvement at all. Whereas these people are making leaps and bounds in their recovery. And it was reported in the discussion that the participants who had this transfer they had a previously paralyzed hand, right? But they were able to do things like getting dressed, skills that require dexterity, such as tying shoes, something that requires strength and isometric control, like wringing out a towel, or something as precise as operating a mobile phone. All of these were possible with the previously paralyzed hand following this procedure. And I really hope that the people who are in the control study got a discount on surgery because, man, I would be upset that I missed out on that. So yeah, I was always left wondering, like, all right, well, what happens if we're connecting the opposite side of our brain? We're you know what I mean? We're connecting the left side of our brain to the left side of our body, because we know that the left side controls the right side controls the left side. But what happens if the left side controls the left side? We literally see a migration over time of the signals. So, normally this is going to be generated on the right side if it's controlling the left, but eventually these signals that we previously were using to control our left side are now being taken over by the left side of the brain. And the brain is literally rewiring itself to meet its new peripheral nervous environment, if that makes sense. So these same authors, they took it a step further, and they did a C7 to C7 and an L5 to S1 simultaneously. And the thought here is that locomotion usually happens like I move, you know how like you move your arms and your legs together as you walk, and it's kind of a subconscious thing, but it's opposites working together. They thought that, well, maybe if we take these people who are hemiparetic and we fix both sides at once, maybe they'll have better surgical outcomes. So we have in this study 2 participants, a 36-year-old woman. She has spasticity and hemiplegia in both upper and lower limbs on the left side after a right cerebral hemorrhage, and a 64-year-old man with permanent muscle weakness in the right limbs. And what's nice about the study is that she has left side weakness and he has right-sided weakness. And both of these are, pretty old. And what happened after they fixed both of these patients? So let's see, here's the preoperative scores. And here are the postoperative scores. So in green, I have the female patient, and in red, I have the male patient. Again, Fugel-Meyer is a stroke performance-based study. Berg is a balance scale, and Barthel is a scale of activities of daily living. So the male, he gained about a 25% increase, 50% increase in his Barthel index, and pretty much doubled his ability to balance. Whereas he had already had a pretty high Fugel-Meyer score, but our female participant pretty much doubled her Fugel-Meyer score after undergoing this procedure. Patient 1, which was the female, after 10 months, she had an improvement in muscle strength of her upper extremity. She recovered the ability of wrist extension and flexion, and a finger flexion extension, and reduced lower limb spasticity. She was even able to trot after 10 months. So this is a person who was kind of paralyzed in one side of their body, and they're able to do this very low impact running. The patient 2, he was previously confined to bed for this procedure, and he could only move with help from others or a wheelchair. And now he was able to walk in small steps. He also regained some ability in hip extension, knee flexion. And this is what's most interesting about these findings is that these authors had previously been doing L5-S1 grafts, but they weren't seeing improvements until 16 months post-op. But when they were doing it with the L5-S1 and the C7 to C7 transfer simultaneously, people were recovering a lot faster. They were able to run at 10 months, whereas these people weren't really exhibiting coordinated movement until 16 months. Now we're going to get into brain-computer interfacing a little bit. I'm going to try to do this as seamlessly as possible this time. There's some very interesting videos here. Let's see. Share.
So I know based on how much sensory feedback you're getting in the thumb and how little feedback you're getting in the hand position, that this is a soft eye.
Okay, so that's being done at Florida International University. There's actually a PBS special called Human, the World Within, and they go a lot into Jason Little. He actually has some proprioception around his prosthetic, which enables him to determine whether he's touching a hard or a soft object when he's connected to this limb. And they'll hook him up to a blindfold essentially, and he can still tell what's going on. Now, these are some papers that I am going to be discussing here. This thing called an RPNI. I'm going to explain how they make it and everything, but this is a little introductory video to show you what an RPNI is and what this lab at Michigan has created.
It brings you back to a sense of wellness. It's like you have it handy.
Advanced prosthetic hands on the market can do lots of things.
These are beautiful prosthetics with incredible capabilities, but we've had no way to control them.
To get that kind of control, you really have to go to the nerves.
The problem with most of the technologies we have is that the signals are really tiny. You have tiny little peripheral nerve signals, and you have noise in those signals that's about the same size. So when you try to hear what a peripheral nerve is saying, you actually can't hear it. We designed a way to connect up with the peripheral nerves with a piece of muscle. And then what happens is when the tiny little peripheral nerve signal comes down the nerve, it goes into the muscle and it becomes a huge muscle signal.
We've now seen, to my knowledge, the largest voltage reported from a nerve compared to all previous results. That makes these signals big enough that we can record them and interpret them for controlling a prosthetic hand.
Brought back another night and thought, well, if I had something like this, I could actually output without personally hurting myself.
I think it's a really good step into the future. It's a good way to move forward for not only me, but for other people.
You can make a prosthetic hand do a lot of things, but that doesn't mean that the person is intuitively controlling it. So the difference is the person just thinks about moving. This worked on the very first time we tried it. So now we can access signals associated with individual thumb movement, multi-degree freedom thumb movement, individuated fingers, and this opens up a whole new world for people who are upper limb prosthesis users.
All right, let's see if I can switch this back now. I did it. I'm so proud of myself. All right, can you guys see this okay? All right, thanks, Nick. And here we go. So what is a neuroma? A neuroma is something that we really need to look out for in amputees and people who suffer severed nerves. Basically what happens is you have this severed nerve and it's trying to grow, it's trying to go places, but it doesn't really have anywhere to grow. So you have this really aberrant growth and it just produces a lot of pain. It has a whole bunch of really useless signals going on. And it's just going to constantly be stimulating you and telling you like, ow, I'm in pain. And so a lot of phantom limb pain is actually caused by these neuromas. So we can use these neuromas not only to control limbs, but we can also use them to prevent phantom pain at the same time. And so these things kind of work together to resolve the issue of phantom pain while also giving people greater control again. So there are some things you can do to fix neuromas. So first, obviously, you cut it and then you can implant the nerve into a muscle. You can put a cap on it. You can, I guess, literally reconnect it to itself. You can do this allografting, but what I am really interested in here for the sake of this discussion is this targeted muscle reinnervation and the RPNI, the peripheral nervous interface. So again, here's another image kind of demonstrating what I just said. So this study is just, this one's kind of nerdy. We're going to skip over this one. This one is basically just saying that we're at a point where artificial intelligence is better than direct control because people were using these limbs for control of prosthesis. This was a study done up at Northwestern. Isn't it so beautiful? And basically what we found is that machine learning systems are at a point where they are better than traditional direct control, which we find is more cumbersome and requires a switching mechanism. So they hooked their participants up with this device here. It's just like a clamp, nothing super fancy, but they were basically given to the participants and they had to do activities of daily living with this thing for a while. and they either got the AI or the traditional control. And what this study shows is that, you know, the AI is better. What I really want you to pay attention to here, because this is TMR. TMR, again, is where you're putting the muscle in, you're putting the nerve in a previously working muscle, such as like the pecs. The RPNI is you're creating a muscle for the nerve. So the TMR is a working muscle, something that the person probably uses. The RPNI is a literally useless muscle. But what I really want you to pay attention to is the number of calibrations that these people required for the TMR. And now we're going to go into the study using the RPNIs that we just saw in the previous video. So an RPNI is made like this. So step one is you have a nerve, you sever it, and then you literally roll it up like a little hot dog, and then you put your nerve inside of there. And over time, the nerve literally grows into this muscular tissue, and it sends all the same information to this muscle that it originally sent to its normal host. So this is some examples of the participants in the study. Please don't get overwhelmed. We're not going to mull over these details. We're going to burn through them, actually. So you can see that different participants had different amounts of RPNIs depending on how many free nerve endings they had. And one had a bunch in their chest. These had them this one had them in the elbow, and these were in the hand for the wrist region. But this one only had 3, and this one had 4, just based on the job that the surgeons had done or complications with their previous amputation. So here's a video. This video demonstrates what happens when we're trying to get the thumb to flex in the RPNI. You can see that the RPNI is contracting in a very unique manner. Now, when we try to get it to contract for the index finger, a different series of information is sent into this muscle hot dog, and it contracts differently. And here we have, again, small finger flexion showing us a different signature on our ultrasound. And ultimately, these things are going to be in very large amplitudes on an EMG. So this is another patient, and his are pectorally implanted. So he's flexing his thumb using an RPNI that's implanted in his chest. And you think, oh, wow, like this person has to have lost this ability to flex their thumb using their nervous system, but the signal is still there. It's still there, and it's we can still harvest that and use it to control things. So I hope that inspires you guys for what we can do in the future for people who are missing their entire arm. It's not that we lost their signal somewhere along their peripheral nervous system. It's quite literally still there. We just have to be creative about our ways in using it. So basically, let's see here. All right, now we can go on to the fun stuff. So what they did is they decoded a bunch of different finger postures on the participants, and then they had a computer program, and the participant was asked to match how fast the computer, so the computer program will show them a hand gesture, and they have to try to copy the hand gesture. And there is a really, really slow delay. I mean, this is almost instant that these people are able to use this robotic hand to match the gestures that the computers ask them to do. So here's a video demonstrating this. And then here's another one. I can't remember which participant is the one who has the RPNIs in their chest. But you can see how quickly we're able to match the computer. It's almost as fast as if it was a real person. So remember in the previous study, I was kind of ragging on them because they had to calibrate their equipment about like 60 times. Well, this is a validity check after 300 days with no calibrations. I mean, look at that precision. It's incredible. This person went almost a full year without having any recalibration done. And their signals produced by the RPNI are so clear and robust that they don't need to be recalibrated. And that means that we may be able to give people limbs that they can use for long periods of time without having to constantly come back to the doctor's office to get it fixed. That it's not only reliable, but it has some longevity to it too. This is really interesting here. This is showing the degree of freedom of movement for the thumb. And you can see that they're trying to match this thing as it moves really, really quickly. And they are able to follow it. And the most difficult thing is we need the thumb, right? Because the thumb enables us to grasp objects and do all kinds of things that make us human. All right, and moving on. Let's see, it's not necessary. So this is where it's cool. It's a performance testing. I love this video. Look at that. This is known as the box and blocks test. It's a test that we'll do on people with upper limb extremity. And it's you have 60 seconds to put as many blocks as you can over this little 4-inch wall. Most people who suffer from strokes, they can usually get like 2 in a minute. So the fact that he was moving so quickly is really incredible. All right. Yeah, it's the same guy. And here is the last paper we're going to go over in our last few minutes here. This is the future of brain-computer interfacing and prosthetic limbs. So the issue with an RPNI is that these are very fragile things. They're in the muscle and they are peripheral. They're subject to trauma. They can be damaged. They can be destroyed. And it's also not, it's still not a direct control nerve to machine interface. So it's nerve to muscle to machine. And there may be some ambiguity in the signal there. So this is, I think, the next stage, and this is what we can expect to see in the future. It also seems incredibly painful. So basically, what they're doing is they're looking at taking people's nerves and sewing them into the medullary cavity of a bone and then connecting to the nerve inside of the bone. So bone offers stability and protection. And then we found that nerves in the bone remain physiologically active and can respond to stimulation required for the control of prosthesis. And apparently it's a pretty easy surgery, according to the people that do this. I cannot imagine how. So first things first is we had 6 New Zealand rabbits. They went through an amputation and now they're not happy. And here we have an image showing us that we have our nerves coming in through these little holes that they drilled here. And then there's this interface, this theoretical interface, which would house the nerve and read its signals. We would have this abutment, and the signals would be transferred down into here, into some kind of, I guess, ankle or arm or something like that. I'm assuming you could do this in the femur or the humerus. this was more of a feasibility study. So basically they proved that the procedure was fast and easy. There were no signs of neuroma formation with this approach. And the next step for these authors is to try to connect this into some kind of prosthetic limb and then put the limb on the rabbits. And then so the rabbits will be using this intermedullary thing to control a pseudo limb using robotics and stuff like that. And so osseointegration is necessary for more stable load bearing and longevity and protection. So that is pretty much all I have for you guys. Thank you so much for coming to this and listening to me talk. I guess I'm not an expert, so I don't know if I can answer too many questions, but if you guys have questions, please let me know. I guess we can open up the chat for a little while.
Awesome work, TJ. Really good presentation. This is going to be great for the undergrads. And it was really helpful for us too. I have a question about the bone, especially like the frequencies that they were talking about, because before I thought the whole point of the RPNI was that the reason why you wrapped it in muscle was so that you could get an increase in amplitude of the signal so that you could actually get the prosthesis to do what you wanted it to do. Does that problem persist if you just put it into bone without having a muscle to help amplify that signal?
Yeah, I think that the signal would definitely be less broad if it was inside of the bone. But the discussion on this article suggested that they could use a higher specificity. And that the issue currently is that there's micro damage caused to the nerves when they're connected to an electrode. I'm not totally sure. I really wish I knew more about this because I kind of wonder the same thing because they both. I'm not sure which one would be better.
That's fine. I mean, it sounds like it's being addressed really well, and I think, I mean, that is going to have to be the next step, right? We're always going to have to keep evolving this just to keep it moving forward. But there's been a lot of exciting development. So thanks for your hard work.
Thanks. I want to thank you guys too for allowing me this platform to give this talk and share this with you guys. It's really cool. And thanks everyone for coming out too. Does anybody else have any questions or anything like that?
Okay, well, if nobody has other questions, we'll let everybody hop off the call. TJ, thank you so much for your time. And wow, I'll stop the recording.